our topic is amenorrhea. Amenorrhea means absence of menses. It is a symptom, not a disease. Prevalence of pathological anemia is 3 to 4%, and the basic factor for onset and continuation of the normal menses are normal female chromosomal pattern, coordinated hypothalamo-pituitary ovarian axis, rhythmical presence and patency of the outflow tract, responsive endometrium, active support of thyroid and adrenal gland. This is coordinated HPO axis. From hypothalamus, there is secretion of GnRH hormones that give positive feedback on pituitary. So there is release of FSH and LH hormone from the pituitary. It acts on the ovary. This causes release of estrogen and progesterone from the ovary. Clinical types of amenorrhea. So the amenorrhea may be pathological and physiological. Physiological amenorrhea may be primary before the puberty and secondary during pregnancy, lactation, after menopause. Pathological may be when amenorrhea may be concealed type. This is called cryptomenorrhea, and rare type, that is called true amenorrhea. Cryptomenorrhea may be congenital type since starting because of some pathological abnormality of the genital tract and may be acquired. Rare type pathological amenorrhea may be primary and secondary. Clinical type of and physiological type. Before puberty, the pituitary gonadotropins are not adequate enough to stimulate the ovarian follicles for effective estrogenesis. Estrogen levels are not sufficient enough to cause bleeding from the endometrium. During pregnancy, there is large amount of estrogen and chorionic gonadotropins from the trophoblast that suppress the pituitary gonadotropins. This leads to no maturation of the ovarian follicles. During lactation, there is high level of the prolactin which inhibit ovarian response to FSH. So there is no follicular growth. This starts a hypoestrogenic condition. So there is no menses during the lactational period. If the patient does not breastfed her baby, the menstruation returns by 6 weeks following the delivery in about 40% of the patient and about 12 weeks in 80% of the patient. If the patient breastfeeds her baby, the menstruation may be suppressed in about 70% of the patient until the baby stops breastfeeding. Following menopause, there is no more responsive follicles in the ovary for the gonadotropins to act. As a result, there is cessation of the estrogen production from the ovary. Pathological type of amenorrhea. First is cryptomenorrhea. It is periodic shedding of the endometrium and bleeding, but the menstrual blood fails to come out from the genital tract due to obstruction in the passage. The cause of pathological amenorrhea, cryptomenorrhea, are congenital. This is because of imperforate hymen, that is the most common, transverse vaginal septum, and atresia of the upper third of the vagina and cervix. Acquired cause may be due to stenosis of the cervix following amputation, give cauterization and conization. Secondary vaginal atresia following neglected and difficult vaginal delivery also cause cryptomenorrhea. Pathology. There is accumulation of the blood in the uterine cavity. This results to hematoma. The blood may enter the tubes. This leads to familial blockage, resulting in hematometra of the tubes by blood. This is called hematosalpinx. So there is blockage of the tube. This leads to hematometra and hematosalpinx because of collection of blood inside the uterine cavity and the tubes. Clinical features. Patient may present with amenorrhea dated back from the event. There is periodic pain in the lower abdomen in every cycle. There is on a pelvic examination, there is offending lesion present inside the vagina. The uterus is symmetrically enlarged. Treatment in simple dilatation of the cervix so as to drain the collected blood is secondary atresia of the vagina, reconstruction, surgery to maintain the patient patency, and cruciate incision in case of imperforate hymen. Primary amenorrhea. Definition. A young girl who has not yet menstruated by the age of 16 years, the upper normal limit for menarche is 15 years. Lower mean age of the menarche is at 14 years. in the absence of secondary sexual connectors, and 16-year in the presence of the secondary sexual connectors. Causes: hypergonadotrophy, hypogonadism, primary, this is called primary ovarian failure. So there is high secretion of gonadotropins, but there is decreased level of estrogen progesterone. Resistance ovarian syndrome, galactomenorrhea, due to premature ovarian failure, there is deficiency of the 17-alpha hydroxylase enzyme. This characterized by decreased cortisol and increased ACTH, increased mineral cortical production. Other gonadotropin receptors mutation, imperforate hymen, transverse vaginal septum, atresia of the upper third of the vagina and cervix, complete absence of the vagina, and absence of the uterus in MRPH syndrome. Hypogonadotropin, hypogonadism. Causes are delayed puberty, delayed GnRH pulse reaction, hypothalamic and pituitary dysfunction, gonadotropin deficiency due to stress, weight loss, excessive exercise, anorexia nervosa, chronic disease like tuberculosis. Kalman syndrome, there is inadequate GnRH pulse secretion, reduced FSH-LH, central nervous system tumor like craniopharyngioma, reduced GnRH secretion, reduced FSH-LH level, abnormal chromosomal pattern like Turner syndrome, which is the most common cause of secondary primary amenorrhea, various mosaic state of the chromosomal abnormality, pure gonadal dysgenesis, androgen insensitivity syndrome, also known as testicular feminization syndrome, partial deletion of the X chromosome. Dysfunction of the thyroid and adrenal gland like adrenogenital syndrome, cretinism, abnormal metabolic disorders, juvenile diabetes, systemic illness like malnutrition, anemia, weight loss, tuberculosis, and unresponsive endometrium like in congenital uterine sanity because of tuberculosis. Now, investigation in case of primary amenorrhea. If the normal secondary sexual collector develop, firstly we do pelvic sonography or laparoscopy. If the pelvic sonography there is absence of uterus, we will do karyotyping. If there is normal karyotyping, then this may be a cause of the cause may be Mullerian agenesis in condition where the chromosomal pattern is 46XY. This is because of adrenal insensitivity syndrome. In sonography, when the uterus is absent, then we test for normal anatomy of the uterus and genital system. If the FSH and LH, TSH and prolactin stimulation, and then go for this hormonal stimulation. If the hormones level are low or normal, this is physiological delay or hypothalamic cause. In case of elevated LH ratio FSH, then this is a cause of the cause is PCOS. If FSH and LH both are raised, premature ovarian failure, resistance ovarian syndrome. If there is abnormality of the SS, this may be because of hypothyroidism or hypothyroidism. If there is increased prolactin level, this is called hyperprolactinemia due to pituitary tumors. In absence of secondary sexual correction, first we measure the height of the patient. If the height is normal, then we go for FSH LH level, and FSH LH level is high, then we go for karyotyping. In case of normal karyotyping, the cause may be primary ovarian failure, resistance ovarian syndrome. In case of 46XY karyotype, there may be cause for the cause may be gonadal agenesis. If the FSH LH level is low or normal, the cause may be physiological delay or syndrome. In case the height is short, then we go for FSH LH level again. If it is low, hypothalamo-pituitary dysfunction or intracranial lesion. If it is high, then we go for karyotype. Now, type of amenorrhea. Type of hypogonadism. It may be hypergonadotropic. It may be hypogonadotropic. In case of hypergonadotropic hypogonadism, serum FSH-LH level is high, more than 30 milli international unit per ml. Estrogen level is low. The cause is in ovary. In case of hypogonadotropic hypogonadism, FSH level and LH level is low. It is less than 5 ml per ml, 5 milli international unit per ml. Estrogen level is low in this case, and the cause is in hypothalamus or pituitary. Eugonadotropic condition, both hormones levels are normal, and pathological condition will vary. How will you manage a case of amenorrhea? First, developmental amenorrhea. In case of complete agenesis of vagina, we need vaginal reconstruction. In case of chromosomal abnormality like in Turner syndrome and other type of gonadal dysgenesis, combination of estrogen progesterone cyclical treatment with estrogen progesterone is required for development of the breast. In case of androgen insensitivity syndrome, the ectopic gonads are to be removed only after the maturation of the secondary sexual characters, because hormones are required for the development of the breast. Substitution therapy after gonadectomy is indicated to maintain the secondary sexual characters. Hormone replacement therapy with conjugated equine estrogen pre-married 0.625 mg daily is adequate. Hypothalamo-pituitary ovarian axis defect. Patient with delayed puberty should be counseled and reassured. Puberty may be induced by use of oral contraceptives or by progesterone therapy when there is severe delay. In case of mild disorder, ovulation and menstruation can be induced by gonadotropies or GnRH analog. Kalman syndrome. Pulsatile administration of GnRH is used for induction of the ovulation. Estrogen and progesterone therapy is given for menstruation. Hypothalamo-pituitary tumors are required surgical excision or radiotherapy. Thyroid and adrenal dysfunction. Thyroid hypoplasia like creatinism. Replacement therapy is required. Adrenogenital syndrome with enlarged clitoris. This needs clitoroplasty. Estrogen corticosteroid replacement therapy is given in case of 17 hydroxylase deficiency stage. Prolactin needs requirement either by medical treatment or by surgical treatment. Metabolic and nutritional causes of amenorrhea like diabetes and tuberculosis. Anti-diabetic and anti-tubercular drugs are required in these conditions. Correction of anemia, nutritional status, malabsorption syndrome, weight loss, stress, chronic diseases, and may resume menstruation. Responsive endometrium. Endometrial uterine synecdoche of tubercular origin. Anti-tubercular treatment is required along with the adenolysis and intrauterine contraceptive device inserted inside the cavity after adenolysis. Secondary amenorrhea. What is the definition? It is absence of menstruation for 6 months or more in a woman whose normal menstruation has been established. Causes may be hypothalamic, pituitary, ovarian, uterine, and systemic causes. Hypothalamic causes stress after use of oral contraceptive pills, excessive weight gain or excessive weight loss, and drugs like psychotropic drug, antihypertensive drugs. Pituitary cause may be adenoma or Seymour syndrome. Ovarian cause PCOS, premature ovarian failure, synecdoche, uterine synecdoche, and systemic cause malnutrition, hypothyroidism, and diabetes. Etiology, uterine causes. Tubercular endometritis after radiation, synecdoche, and surgical removal of the uterus. Ovarian factor, PCOS, premature ovarian failure, resistance ovarian syndrome, chemotherapy like from alkylating agent. Hyperestrogenic state, persistent follicle in the metropathia hemorrhagica, humanizing tumor of the ovary like granulosa cell tumor, androgen axis muscularization tumor of the ovary like theca cell tumor, hypoestrogenic state like hysterectomy and pelvic radiation with pituitary factors like adenoma, Cushing syndrome, acromegaly, Sheehan syndrome, and Simon's disease. Hypothalamic factors like psychological shock, stress, anorexia nervosa, and excessive exercise, and pseudocyesis. Congenital malformation, trauma, accident, surgery, or radiotherapy, infections like tuberculosis and sarcoid melanoma, tumors like prenuphagioma, meningioma, pituitary adenoma, adrenal factor like adrenal glands, hyperplasia, Singh syndrome, thyroid factor, hypothyroidism state, journal factor, malnutrition, tuberculosis, chronic nephritis, diabetes. Iatrogenic cause, contraceptive pills, psychotropic drugs, antihypertensives. Clinical features and diagnosis. In case of uterine factor like tubercular endometritis, the diagnosis is obtained accidentally by following diagnostic curate or at laparotomy or laparoscopy. Uterine synecdoche, as a Munch syndrome. There is formation of adhesions following post-abortal prepared for curate and diagnostic curetas in dysfunctional uterine bleeding. Menstruation abnormality, it leads to hypomenorrhea, oligomenorrhea, or amenorrhea. Progesterone challenge test is negative in case of Asherman syndrome. Hysteroscopy, hysterosalpingography, we can see honeycombs pattern, and hysteroscopy reveals the extent of adhesions directly by visualization of the endometrial cavity. This is a picture, agency picture in case of tubercular endometritis. We show honeycomb pattern of the uterus. Management of uterine synecdoche. Hysteroscopic adhesiolysis followed by insertion of IUCD is effective method for treatment of uterine synecdoche. Addition of the oral contraceptive pills for 3 months may help in regeneration of the endometrium. Successful pregnancy and live birth is reported in 70 to 80% of the cases after the treatment. There may be recurrence in about 30% of the cases. Ovarian factor. PCOS. Polycystic ovarian syndrome was described by Steen and Leventer. It is characterized by amenorrhea, hirsutism, obesity associated with enlarged polycystic capsules. It is most common disorder of reproductive age group found most commonly between the age of 25 or 20 to 40 years of the age. The incidence in reproductive age group is 20 to 30%. Now, etiology. PCOS is multifactorial condition characterized by excessive secretion of androgen produced by ovaries. There is dysregulation of the CYP11A gene, insulin receptor gene on chromosome 19p32. Diagnosis is based upon the presence of any of the two following three criteria. Oligo or amenorrhea, this hyperandrogenism, and clinical and biochemical condition, PCOS. Pathology and histopathology. The ovaries are enlarged, ovarian volume will increase, that is more than 10 centimeter cube. There is increased volume of the stroma. The capsule becomes thickened and pearly by presence of multiple follicles more than 12, that is measuring from 2 to 9 millimeter in diameter. These are crowded around the cortex to make it prehistoric appearance. Histopathology. This thickening of the tunica albuginea, that is the capsule of the ovary, the cyst of the follicle consists of varying stage of maturation, and in atresia, there is thicus and hyperplasia hypertrophy. So there is stromal hypertrichosis. Patient may present with insulin resistance. Clinical features of the PCOS. This increased abdominal obesity in 50% of the cases, menstrual abnormality in 70% of the cases, which is present in form of oligomenorrhea, amenorrhea. Some patients may present with DUB or infertility. Hirsutism and acne present in 70% of the cases. Acanthosis nigricans is characterized by specific skin changes Due to insulin resistance, the skin is thickened and pigmented. Commonly affected area are nape of the neck, inner thighs, groin, and axilla. Hair and syndrome, hyperandrogenism, insulin resistance, acanthosis, lifestyles. This form hair and syndrome. Internal examination revealed bilateral and large cystic ovary, which may not be revealed due to obesity. In this picture, we can see acanthosis nigricans in case of PCOS. There is thickened layer, velvety layer over the neck of the neck. What are the investigation required in case of PCOS? Sonography. Transvaginal sonography is useful in ovaries who have BMI more than 25. Ovaries are enlarged in volume and there is increased number of peripherally arranged cysts. LH level is elevated or there is increased ratio of LH to FSH. Raised level of estradiol and estrone, the estrone level is markedly elevated. Serum hormone binding globulin is also decreased in case of PCOS. Hyperandrogenism, mainly due to ovary, but less from the adrenal gland. Adrenostenediol is raised. There is raised level of the testosterone and DHEAS. Insulin resistance is present. Raised fasting insulin level more than 25 micron international unit per ml. Fasting glucose and insulin ratio, there is decrease in this ratio. Level of the serum insulin response is increased at 2 hour postprandial glucose load. This is called severe insulin resistance. On laparoscopy, we can see bilateral polycystic ovary. This is a picture, transvaginal sonographic picture of the ovary which show multiple peripherally arranged follicles. These are in various stages of maturation and vary in size. Pathophysiology. Hypothalamic pituitary compartment adrenal, the pathology lies in hypothalamus, there's androgen axis, anovulation, there is obesity and insulin resistance and what long-term consequences of this condition. Hypothalamic pituitary compartment in PCOS. This increased pulse frequency of GnRH from hypothalamus. This lead to increased pulse frequency of LH. Leptin, insulin resistance, and hyperandrogenemia are responsible for this. GnRH is preferential to LH rather than FSH. Increased pulse frequency and amplitude of the LH result in tonically elevated level of LH. FSH level is not increased. This is mainly due to negative feedback effect of chronically elevated estrogen and follicle. Increased free estradiol due to reduced sex hormone binding globulin. The LH-FSH ratio is increased.
मैं बता क्या बोल रही हूँ आपको लंबा चलेगा मैं ये देख रही हूँ बहुत लंबी ये बहुत लंबा चलेगा अपन ये इस से छोड़ के मतलब ये बस करते हैं पीछे
कितना देर का हो गया अभी
काफी देर हो गई मतलब 20 मिनट तो हो गए अपने
नहीं हो गए मुझे इतनी तेज नींद
मैं बोल रही हूँ पॉज करते हैं इसको यहाँ पे ले लेते हैं एक दो स्लाइड ये अपन कौन सी स्लाइड पर है
कौन सी स्लाइड वही मैं देखना चाह रही थी कि बच्चे 10 मिनट ही बचे
ओवेरियन ड्रिलिंग और ये सब नहीं बताना है तो जो इस हिसाब से तो कुछ नहीं ये जो आपको वहाँ लग रहा होगा ना मेन का वो आप रीड आउट करके
अभी अपन कहाँ पहुंचे
ये हाइपोथैलेमिक के फॉर्म ये
जी सर मैनेजमेंट
सीधा मैनेजमेंट में आते हैं उसके बाद
मैनेजमेंट में ये दो स्लाइड आ जाएंगे मेटाबॉलिक सिंड्रोम ये सब नहीं होता फिर सर्जिकल ट्रीटमेंट है ना इसको डॉक्यूमेंट नहीं किया इसके वाली स्लाइड immature ovarian ये वाला premature ovarian failure.
हम कोई अगर टॉपिक लगाए तो अपन उसकी सिर्फ लाइन बोल रहे हैं
हालवान सिंड्रोम ये सब नहीं पढ़ाएंगे, ये फैक्टर ये सब नहीं, राजन ये सब नहीं पढ़ाएंगे, शिनान सिंड्रोम ये सब पढ़ाना उससे। सारा डिस्फंक्शन बढ़ा दिए सीधी। मैं आती हूँ पानी पीने, तो मैं सो ही जाऊंगी।
चाय भी आई थी आप क्यों अपन ने वापस भेजी, मैं इसी तभी पॉज कर देते हम पाजो पॉज है अभी तो वो कंटिन्यू हो जाएगा।
हाँ मैं आती हूँ, पॉज है ना,
हम पॉज है
बस संसा में 10 मिनट और बोलने हो जाएगा,
खाना निकालेंगे। अब इसको मैं सीधा
नींद आने लगी थी, चाय भी नहीं
मैनेजमेंट
मिली।
पे आती हूँ। क्या हो रहा है
अब नहीं मिल रही।
यहाँ पे सीधा मैनेजमेंट में लगा रही हूँ बस यहाँ से अपन कंटिन्यू करेंगे।
Now, management of PCOS. The treatment is primarily targeted to correct the biochemical abnormality like hyperandrogenemia, hyperinsulinemia, hyperlipidemia, high serum estrogen level, androgenic ovarian follicular microenvironment, hyperprolactinemia, insulin resistance, hypersecretion of the LH, low serum hormone binding globulin, low FSH, low serum progesterone, and hyperthyrocystinemia. First is weight reduction. If the patient is obese, advise the weight reduction. This automatically correct menstrual disorders. It improves the infertility. It improves fertility and impair glucose tolerance. Metabolic Metabolic disorders in hyperinsulinemia give metformin. It increases the insulin sensitivity, decrease weight loss, and gain, and reduce serum hormone, serum lipid, low density lipoprotein cholesterol. Now, metabolic syndrome. What is metabolic syndrome? It consists of triglyceride level more than 150 milligram per deciliter, HDL cholesterol level less than 50, blood pressure more than 130/85, fasting glucose level more than 110 milligram per deciliter, and waist circumference is more than 78 centimeter. Treatment correction of the hyperandrogenemia is by combined oral contraceptive pills, progestin suppress LH, and improve estrogen, improve serum hormone binding protein. Hirsutism is due to anovulation, high androgen and insulin level. Correction of the metabolic syndrome improves it. Anti-androgens also tried for the case of hyperadrenaline.
पॉज कर लो है ना आगे बढ़ते हैं ये नहीं क्या प्रीमेच्योर ओवेरियन इनसफिशिएंसी
एक तो हो जाए आज कम से कम. Premature ovarian failure is defined when the ovary failure occurs before the age of 40. It occurs in 1% of the female population. During intrauterine life, either there is failure of germ cell to migrate or there may be normal germ cell migration but accelerated rate of germ cell depletion. This results either no follicle or only few follicles in the ovary by the time they reach the puberty. The causes of premature ovarian failure most common is Turner syndrome, congenital dysgenesis, trisomy 13 and 18, chromosomal X deletion, translocation, autoimmune cause, infections, iatrogenic cause like radiation, metabolic cause like galactosemia, and environmental cause like smoking. How to diagnose? History of aneurysm in less than 35 years of age on a blood serum marker examination. Gonadotropin level is FSH level is high, as in case of menopause. Serum estradiol level is low. Karyotypic abnormality is present. Management: hormone replacement therapy, corticosteroid, induction of ovulation by administration of the estrogen and progesterone or by GnRH, IVF with donor oocyte, and in presence of bichromosomal gonadectomy to be done to avoid malignancy.
कैलविन्स नहीं पढ़ाना ना श्रीवास्तव नहीं पढ़ाना फैक्टर्स क्या बचा मैनेजमेंट ऑफ हाइपोप्रोलैक्टिनेमिया इज पैचन
Pituitary factor, pituitary factor. Pituitary factors of pituitary factors like adenoma, hyperprolactinemia, pituitary adenoma like prolactinoma. Causes of hyperprolactinemia. It may be physiological in case of stress, exercise, pregnancy, sleep, or maybe idiopathic. Hypothalamic and pituitary cause: craniopharyngioma, tuberculosis, hypothyroidism, pituitary adenoma, drugs like alprazolam, cimetidine, renal failure, and PCOS and cirrhosis of liver. How to diagnose pituitary adenoma? Normally, prolactin level is less than 20 nanogram per ml. In case of pituitary adenoma, prolactin level is raised more than 100 nanogram per ml. In case most of the microadenoma and macroadenoma are less. Visual field effect is essential to detect any compression effect of the optic nerve. It is diagnosed by CT scan or MRI. Management of hyperprolactinemia. Treatment: medical. Bromocriptine, it is a dopamine agonist. First choice of drug, cabergoline. It is also a selective dopamine agonist. Transnasal surgery, surgical treatment, transnasal, transsphenoidal adenectomy. Thyroid dysfunction. Both hypothyroidism and hyperthyroid state may lead to secondary amenorrhea and anovulation. Serum TSH level is raised in case of hypothyroidism, while TSH and T4 level are lower. Serum prolactin may be raised even beyond 20 nanogram per ml in hypothyroid state. Management of hypothyroid state: thyroxine supplementation therapy, thyroxine 1.6 microgram per kilogram of body weight is required. Post-pill amenorrhea, it is observed in case of 1% of the women following the use of combined oral contraceptive pill. Fertility rate is normal following discontinuation of the treatment. Spontaneous resumption of the menstruation occur in majority of the cases. Otherwise, such amenorrhea should be investigated as in other cases of anemia.
कन्वर्शन हो गया इसका पूरा